Hello, and welcome to the EMJ Dermatology webinar. This episode will explore improving patient adherence to treatment, consideration of why patients are non-adherent, and what physicians can do to improve adherence. My name is Naya Malik, and I'm editorial manager of the EMJ family of journals. Our presenter today is Stephen Feldman, professor of dermatology at the Wake Forest University School of Medicine in North Carolina, USA. Thanks for joining us today to present this webinar, Steve. We're delighted to hear your presentation. I'm now passing it over to you.
Hi, I'm Dr. Steve Feldman, professor of dermatology at the Wake Forest University School of Medicine. I'm going to get to talk to you about my favorite topic, improving adherence to treatment. I have a bunch of conflicts. Basically, you can assume if I mention a product, I've had support from the company that makes that product. I also involved with Sensile Health. They make devices for measuring adherence to treatment. All right, let's start with a case. I saw a 2-year-old child brought in by her mother, who was a registered nurse, and this child had unrelenting atopic dermatitis for basically her entire life, despite using triamcinolone ointment, according to mom, every day, which is shocking to me because if you take people with atopic dermatitis, put them in the hospital and put triamcinolone on them, they all clear up right away. So I tried to convince the mom to take the triamcinolone really well, and she's like, "You're not listening to me. I've been doing this every day. It's not working." So I said, "Well, all right, we can use clobetasol for a few days, and then we'll switch back to the triamcinolone." She calls me the next day, or sends me a message the next day saying, "You were right. I just wasn't using enough triamcinolone. I put the triamcinolone, you gave me a big jar of it. I used it, well, and the next day the eczema was dramatically better." When we see patients with conditions that should be getting better and they're not getting better, whether it's resistant eczema or resistant hypertension, if they're not improving as you might expect they should with treatment, seriously consider the possibility that they're not using the medicine. In this lecture, I'm going to talk in terms of skin disease, but it's just a really great model for understanding adherence, because adherence to topical therapy is abysmal. And so if you understand adherence issues in dermatology, well, then you can understand adherence issues across all of medicine. So we'll talk about how poorly patients are using their medicine. We'll talk about whose fault it is, and I think generally it's the doctor's fault. And we'll talk about all the things we can do to get people to use their medicines better. All right, first, what is adherence? Well, it's not just how often patients use the medicine. We write a prescription. It starts with whether they fill the prescription and start the therapy. That's primary adherence. Secondary adherence is how well they use it and whether they stop early. My patients often don't fill their prescription. If they do fill it, they don't use the medicine very well. One of the best studies done on primary adherence in dermatology was done in Denmark, where they have a national database where they can look to see if people filled their prescriptions. And in this study, they found that roughly 90% of acne and infection prescriptions were filled within 2 weeks, which might sound good, but that's really horrible if 10% of patients aren't filling the prescriptions. If 10% of cars just didn't work, or you never received the car when you paid for it, you'd be like, that's totally unacceptable. But we sort of accept 90% is good. A third of the eczema prescriptions weren't filled. Half the psoriasis prescriptions weren't filled, probably because the doctor prescribed an ointment and the patients were tired of using ointments. My research on adherence has used these funny looking medicine bottle caps that contain computer chips that record the day and time people open and close the containers. We did a study in patients with psoriasis where we gave them a topical to use twice a day. They were supposed to fill out diaries, and the computer chips recorded whether the patients used the medicine. We didn't tell them about the computer chips. They probably thought we were monitoring them using these diaries. This anal retentive patient who filled the diaries out very carefully used the medicine pretty much twice a day like they were supposed to. Here's another diary where it looks like they used the same pen every day for an entire month to record their use of the medicine. They didn't fill it out very compulsively. They scored it to the nearest hour. Kind of looks like it might have looked if they filled it out on the way into the office. According to the computer chips, they almost never opened the bottles. Here were the first 10 patients we studied. You see a range of different behaviors here. Yellow is what they did according to the computer chips. Orange is what they said they did in their diaries. This subject here, number 7, used it exactly the way they said. This is a typical anal retentive patient, you know, a CPA, an architect, an engineer, anybody who brings you a multicolored spreadsheet showing you exactly what they're doing is probably using the medicine pretty well. These subjects, numbers 4 and 6, are saying they're using the medicine, but they're barely ever putting it on. One psychiatrist told me the technical term for this is antisocial personality disorder. When I asked dermatologists what they would call this, they call them liars or something like that. I call this normal patient behavior. These people are normal research subjects who are being told they're being monitored, they're filling out daily diaries, they're being given the medicine, so you don't have to worry about primary non-adherence. They're being paid as part of the study. They're using the medicine much more than real life patients. I think this is more like what real life patient behavior is like. The study we did had, if I remember right, about 30 subjects. It was an 8-week study. So here's adherence on each day of the study. Here's the average adherence. Blue dots is what they said they did in their diaries. Pink dots is what they actually did. And you can see that there's a difference. People say they're using the medicine, they're not actually using it. The first day of the study, they used the medicine well, but then the use of the medicine drops very rapidly over the next few days. But then it settles into a more slow decline, seems to be fairly steady, that it goes down. But it looks like every 2 weeks, the use of the medicine goes up. What is going on in people's lives that makes them use the medicine more every 2 weeks? Well, obviously, it's the every 2-week return visits in the clinical trials. The technical term for this is white coat compliance. I call it the dental floss phenomenon. People use their medicines right before they come see us. That's why we have to use the hemoglobin A1C and not their blood sugar on the day of the visit to assess their diabetes control. This is why blood levels are almost useless for assessing, you know, diseases. I feel for the seizure experts who are using blood levels, you know, to assess what's going on, because they'll like measure a blood level of some seizure drug in a patient who's having breakthrough seizures, and the blood level's in the middle of the normal range. So they'll conclude, well, this drug's not working for you, we'll have to add another drug. Well, the reason the drug's not working, they're having breakthrough seizures, is because between the visits, they don't take the medicine. Before the visit, they take it, and so they get a normal blood level of the drug. In dermatology, the most common phenomenon that we see is the mothers of the acne patients telling us, it's so frustrating. You always catch it on a good day. Well, of course we catch it on a good day, because right before the visit, they take their medicines. Now, the use of the medicine is going down steadily over time by about 20% every 5 weeks. You know, I don't know if it continues going down at that rate, but if it did, then in 25 weeks, the use of the medicine would go to 0. We have a term for that in dermatology. We call it tachyphylaxis. Now, we used to think tachyphylaxis was the more you use it, the less it works. It's actually the less you use the drug, the less it works. Most of the diseases we treat are long-term diseases. We looked at long-term adherence in psoriasis. The use of the medicine dropped very quickly over the first month, and then, gosh, over the course of the year, what is it? 1 in 5 or fewer patients are using the medicine on any given day. Now, this is research subjects. You'd like to know, what do real-life patients do with their medicine? So we once proposed to the Human Subjects Committee that they let us take children with eczema and give them triamcinolone with the computer chips on top without telling the child or the parent that they were even in a research study. And you can imagine what the Human Subjects Committee said when we asked them about this. They said, go ahead, do it. And so here's what real-life patients do if you give them the medicine. The use of the medicine dropped by 70% over the first 3 days. Then it continued to go down. At day 28, the time of the return visit, they use their medicine better. I probably get anybody's eczema clear just by moving that, you know, return visit to 3 days after they start the therapy. That forces them to use the medicine much better. Now, if I'm right, the tachyphylaxis is that they stop the medicine. If we were to take people who fail topical steroids and give them topical steroids under conditions designed to get them to use the medicine, they should get better. And in fact, that's what we did. And that's what happened. They improved. So whose fault is this? Why are patients not using the medicine? The medical literature will tell you there's all kinds of reasons patients don't use the medicine. They're not motivated. They don't trust us. They're fearful. They're lazy. The real reason patients don't use the medicine is we're lousy at getting them to use the medicine. And I'd like to prove this to you with what I call the parable of the piano teacher. My kids took piano lessons. Perhaps you took piano lessons. What happens in the piano lessons? The piano teacher gives you some sheet music, says practice every day, has a lesson with you once a week, and at the end of 8 to 12 weeks, there's a recital, and the recital generally sounds pretty good because people are practicing some every week. What would happen if a piano teacher said, gosh, that's an inefficient system? The reason they sound good is not because of the weekly lessons, but because they practice. So I'll give them the sheet music. I'll tell them to practice every day, and I'll see them at the recital in 8 to 12 weeks. Well, now that recital is going to sound execrable because they're not going to practice without those weekly lessons. A clinical trial, they bring them back at weeks 1, 2, 4, 6, 8, like piano lessons, and that forces people to use the medicine. In real life, the practice of medicine is actually worse than this piano teacher without the weekly lessons. Real life medicine is typically like a piano teacher saying, here's a prescription for some sheet music. Take it to the sheet music store. I have no idea what it's going to cost, whether your insurance company is going to pay for it or not, how much paperwork it's going to take, when you'll be able to get the medicine. But I want you to try to get this prescription filled for the sheet music. Now, I want you to practice this sheet music every day. Practicing this sheet music could cause rashes, diarrhea, possibly a serious infection, but I want you to practice every day. I'll see you at the recital in about 2 or 3 months. Often the recital doesn't sound very good, and if it doesn't, I will give you 2 other sheet musics, or maybe an additional musical instrument to practice at the same time. That's what we're like. If you look at representative data, we're not getting people to use the medicines. We're not creating that sense of accountability. And as a Vietnamese monk once said, if the lettuce is not growing well, you don't blame the lettuce. You have to take responsibility for getting them to use the medicine. At the foundation of getting people to use the medicine is trust and accountability. That's what they don't teach us in medical school. You have to create that sense of accountability. If you do, then addressing the things they teach us about in medical school, like reducing the burden of the disease, giving written instructions, will help. If you do all those things they teach us in medical school, but you don't create that sense of accountability, they still may not use the medicine. And we'll take a few minutes towards the end of this lecture to cover some of the advanced psychological techniques you can use to get people to use their medicine better. So how to improve adherence? Create accountability. If you've been telling people, I'll see you back in 2 or 3 months, see them back in 3 days or in a week. They'll use their medicine much better, their disease will come under control, and then you won't have to see them again. If you're seeing them every 2 months not doing well, that's actually more visits than moving that first return visit to, a 1 week spot. Now, you may not want to bring them back in 1 week. You don't have to. You could just have them call you in 1 week. Just give them your cell phone number or use the portal if you have an electronic system. Have them report their progress in 1 week. If you give them your cell phone number, you don't even have to answer the phone. All that matters is that they think they're going to talk to you in 1 week. You don't have to answer the phone. They'll leave you a message. Doctor, you're right. This medicine worked great. You don't even have to give your cell phone number. If you have a physician assistant or a nurse, you could give their cell phone number. In theory, you could give them a random 10-digit phone number. All that matters is that they think they're going to call you to create that sense of accountability. Now, I do give my cell phone number, but I wondered, can we just do this over the internet? So we randomize teenagers with acne to either standard of care or fill out a survey once a week to report how the medicine is working. And the kids filling out that survey, the use of the medicine more than doubled. It was dramatic impact on the use of the medicine. Other things you can do, sure, simplify the treatment. Once a day dosing. If you want to give people 2 different medicines, give it in one compounded medicine. I I was taught in medical school, oh, avoid those combination products, you know, maybe they're branded, they're more expensive. So, but from an adherence standpoint, giving people something to do once a day is better than giving them two things to do over the course of the day. We tested that in acne patients. Their adherence to a once a day product was better than their adherence to two drugs that were in that once a day product when given separately. You want to give people written instructions. People don't remember anything we tell them. So give the instructions in writing. One mom brought her child with eczema to see me. The kid's skin was dry as could be, had failed treatment from the previous dermatologist. I asked, Mom, what are you bathing the child with? She said ivory soap, which is a very drying and irritating soap, in my opinion. I asked, Mom, what do you bathe? Is that what the previous dermatologist recommended? She said, yes. The previous dermatologist recommended Dove or Ivory. Now, I'm almost certain the previous dermatologist recommended Dove, not Ivory. But patients will not remember even the simplest things. So you got to give people written instructions. And if there's things you're seeing regularly, have a standardized plan so that you don't have to write it out every time. Now, if you give patients a standardized plan, it may look to them like you don't really care about them, that you're just using a standard plan. So what you want to do is you want to give them that standard plan, but you want to make it look like you tailored it specifically for them. So we tested this. We either gave patients this plan or we gave them this plan, which is the same plan, only it looks like it was individualized, and they liked the individualized one better, even though it was exactly the same plan. Triggers and packaging are very, very powerful tools. I could not get my athlete's foot cleared up until I learned to keep my antifungal medicine on top of my socks. You see, if I put my antifungal medicine anywhere else, I'd wake up in the morning, I'd put my shoes and socks on, and then I'd be like, oh, there's the antifungal. I'm not going to take my shoes and socks off. That's too much trouble. I'll just use it tomorrow. And tomorrow came and same thing would happen. But if I had to go through the medicine to get to my socks, you know, I would always remember to use it before putting the socks on. I've had people say, well, why don't you put it inside your shoes? If you put it in the shoes, you may still put the socks on first and not want to take the socks off. Who wants to take their socks off? So I'd put it on top of the socks. Packaging is really critical, and we underestimate its importance. Birth control pills were developed in the 1960s, and they didn't work when they came in a bottle. They switched it to tell you which pill to take which day, and then they suddenly became very effective. Now, you may have some patients who only want to use all natural treatments. I love taking care of those patients because I only use all natural treatments, because I believe all the treatments I prescribe are in fact natural. They're not supernatural, they're found in nature, because CVS, Walgreens, the local drugstores are part of nature. So if I'm giving triamcinolone to a child and mom says to me, is this a steroid? I don't want to lie and say it's not a steroid. So I use a technique I learned watching American presidential debates. I just answer a different question. If she says to me, is this a steroid? I tell her this is an all-natural, organic, gluten-free anti-inflammatory designed to complement your natural healing mechanisms. It brings the skin's immune system back into balance and harmony, because I like to take a holistic approach to the management of skin disease in children. If a drug that you're prescribing has side effects, use them to your advantage. If you're giving spironolactone as an anti-androgen for hair loss or acne, I would tell the woman, unfortunately, this drug's also a diuretic, and you may notice some weight loss while you're on it. I give patients topical solutions for the scalp that contain alcohol, and they may sting. One dermatologist tells me, he tells people this may sting, that's a sign that the medicine is because the medicine is so strong. But people are afraid of strong steroids, so I tell them, this may sting. In my experience, that's a sign that the drug is working, which is true, because if it stings, it means they got it on the scalp, not just on the hair, and that means it's working. If you're taking care of a guy with psoriasis, you might want to tell him, you know, this may sting. A lot of guys don't have what it takes to use this stuff. Okay, if you're trying to motivate kids, I learned this from watching my wife potty train our children, use a sticker chart. This is an incredibly powerful tool. You get some Teenage Mutant Ninja Turtle stickers, blue ones, and you get some pink Frozen stickers. Okay, and then every time the kid does what they're supposed to do, they get a sticker. Now, you probably know that the pink frozen stickers are for the kids who want them. We don't make any predetermined gender judgments because we're woke. All right, teenagers are not going to respond to a sticker chart, and they're certainly not going to respond to their parent hassling them about the use of the medicine. You want a teenager to use the medicine, you tell them this is the medicine most teenagers use in this situation, because teenagers want to be like other teenagers. All right, our time is coming to a close. I want to share with you what I believe are the two most powerful techniques to get people to use their medicine. The first is just one anecdote. If you want a patient to take a medicine, you don't try to sell them on all the data. All you got to do is tell them, you know, I had another patient. You remind me so much of them. Their skin disease was, or whatever disease they have, was so similar to yours. In fact, I think I saw them in this same room. They were sitting in the same chair you're sitting in now. They did great on, and then you name whatever drug you want them to take. That one anecdote is more convincing than all of the data you could possibly give them. Risks, you want to frame risks appropriately. If I showed patients this chart of the rates of serious infection, they'd want to take this drug, not this drug. Okay, this is the rate of 1 in 100 chance. You know, this one has a little less than 1 in 100 chance. This has 2.5% chance of causing a serious infection. If I wanted them to take this drug, I would just show them the same data in this form. This is the number of people who don't get an infection. So 99 out of 100 don't, 98 out of 100 don't. It looks totally the same. So you can bend people to your will that way. Finally, my favorite tool for getting people to use a medicine is anchoring. Human brains do not measure the absolute reality of things. They measure things in relation to another. So if I want people to take an injection medicine, I just tell them, you need to take this medicine every day. Did I say every day? No. It's I'm having a senior moment. It's not every day. You only take this medicine once a month. We tested this. If the drug is once a month and you ask people, would you be willing to take a shot once a month to treat your psoriasis? Their average willingness was only 2 out of 10. If you ask them, are you willing to take a shot once a day for your psoriasis, and then ask them to take it once a month, their willingness to take it once a month is 7 out of 10, because now their brain isn't comparing taking a shot to not taking a shot. Their brain is comparing taking a shot once a month to once a day. This is a very powerful tool. If I want a mother to put triamcinolone on her child twice a day, if I tell her it's twice a day, she's thinking, oh, that's what a nightmare. I got to do this twice a day. So instead I tell her, you got to do this 4 times a day. Do it before school, have the school nurse do it at school, do it after school, and then again at bedtime. She's thinking, oh my God, I got to have the school nurse do this? I'm going to need another container of medicine. I'm going to have to miss work, fill out paperwork, get it notarized. Then I tell her real quickly, I tell her, no, wait, that's a lot. Let's just do it twice a day. She's like, oh, what a relief. I won't have to school nurse twice a day. That's easy. All right. So to conclude, if you're seeing a patient with resistant disease, it may not be because, you know, that they have mutant steroid receptors or something. If they've seen 6 other doctors and they're not getting better, it may not be that those 6 other doctors couldn't make the right diagnosis, prescribe the right therapy. When we see resistant stuff, we need to consider when we see a patient, we need to consider the possibility of poor adherence to treatment. Never label somebody a non-compliant patient because it's redundant. But don't blame the patient. If the lettuce is not growing well, we don't blame the lettuce. We need to take responsibility. The health system, we doctors, drug companies, insurers need to take responsibility to get people to do the things we need to do to get people to use their medicine. And hopefully I've left you with a clear sense that we have tools that we can use to get them to use their medicines better.